Hi everyone, my name is Gurjot Basra and I'm the Manager of Patient Programs, Research and Advocacy at Lymphoma Canada, and I'm pleased to welcome you all to today's session on follicular lymphoma. We appreciate those who have been able to join us live today to learn more about the disease-specific biology and diagnosis of this lymphoma subtype. This presentation will also highlight novel treatment options accessible to Canadians. Before I introduce the speaker, I just want to provide some guidance about the Zoom software for this session. So this virtual software does not allow you to share your video or turn on your microphone. Hence, if you have any questions, please save it for the Indolent Lymphomas Q&A session that follows this presentation. That's where you'll be able to ask your questions to the presenter and get an answer live. So without further ado, to introduce our speaker, today we have here Dr. Pamela Skrbek, who is a hematologist with Cancer Care Manitoba and is an assistant professor of internal medicine at the Max Rady College of Medicine. Dr. Skrbek's research contributions have focused on non-Hodgkin lymphomas with a combination of epidemiological and translational research projects. As lead of the lymphoproliferative disease site group, part of her role is to oversee clinical research activities and collaborate in clinical trials provincially and nationally. She is also a member of Lymphoma Canada's Scientific Advisory Board and is the new chair of LC's Patient and Support Research Committee. So thank you so much for joining us today, Dr. Skrbek, and I'll hand it over to you.
Thank you. And so I'm happy to have the opportunity to speak about follicular lymphoma today. In terms of my outline, I would like to review the basics of follicular lymphoma, including details regarding the diagnosis, biology, and staging. We'll discuss how this disease tends to behave, and also spend the second half of the presentation reviewing treatment approaches in follicular lymphoma, highlighting advances, particularly in immunotherapy, as this is a bit of a hot topic in follicular lymphoma, and with the goal of highlighting what is available now and I expect to be available down the road for patients within Canada. So lymphoma is cancer of lymphocytes, which is a type of white blood cell. There's many different types of non-Hodgkin lymphoma, and the focus of many of the sessions at the conference is to appreciate the variability between the subtypes, and that knowing your specific subtype is important to understand how your diagnosis will expect to behave and be managed. Follicular lymphoma is very common. It's 30 to 35% of cases that we see. It's the second most common B-cell non-Hodgkin lymphoma, and it's the most common indolent non-Hodgkin lymphoma. And so what does indolent mean? Indolent means that that you may not have symptoms, and it's generally a very slow growth over time. Generally, indolent lymphomas are in the lymph nodes in multiple locations, and also the spleen and bone marrow are commonly involved. Patients with indolent lymphoma can have a couple of things happen that are unusual. One is that they can spontaneously regress, meaning they can go into remission with no treatment at all. And the second is that they can transform into a more aggressive lymphoma. Indolent lymphomas really behave like a chronic disease, one that we expect to relapse. They're incurable with current therapies, but very long remissions are possible, and patients tend to have very good outcomes. We treat when we need to alleviate symptoms and induce a remission. We'll talk more about that later in the presentation. So looking at the indolent lymphomas, as you can see here, by far follicular is the most common, with the next most common being marginal zone lymphomas. So just reviewing a bit more about follicular lymphoma. So this is a diagnosis that occurs in all races and all geographic areas of the world. It typically affects people that are older, with the average age around 65. Patients that are young, meaning under 30 or even under 40, are fairly uncommon. The name follicular lymphoma comes from the pattern that we see on the lymph node biopsy that looks like lymph node follicles, but an abnormal follicle, which is a nodular appearance. Follicular lymphoma tends to cause few symptoms, especially when the disease burden is low. It usually responds well to treatment, but it is expected to return at some point. For some patients, though, that may be many, many years. Can transform into aggressive lymphoma, as we discussed before, and I'll talk more about that in a coming slide. So this shows the nodular growth pattern that we expect in follicular lymphoma, and you can see how it looks very different on a lymph node biopsy compared to this growth pattern. And this is really how one of the ways that pathologists recognize very early when they're looking at a biopsy that it's potentially a follicular lymphoma. So one of the things that the pathologist does is they grade the follicular lymphoma. And generally, grades 1 to 2 are lumped together and considered basically the same. There is also grade 3A, which is based on having a higher number of larger cells in a field of view that the pathologist is looking at. Grade 3A is debatable how different it really is than grade 1 or 2, though tends to have higher disease burden and a higher Flippy score, which is a prognostic score at diagnosis, but we tend to manage it the same as grade 1 and 2 follicular lymphoma. Grade 3B follicular lymphoma, though, is a very different diagnosis, really. It's not very common, and it really behaves like an aggressive lymphoma. If you look at the genetics of it, it's very similar to diffuse large B-cell lymphoma. So when I'm talking about follicular lymphoma, I'm really meaning the low grades, which are grade 1 to 2, as well as 3A. Patients usually have painless enlarged lymph nodes that are either found on examination or sometimes on imaging that's done to investigate symptoms, or imaging that's done incidentally. So say you have another cancer and you're getting staged, or you have kidney stones, something like that, we find the abnormal lymph nodes. They can grow and shrink in follicular lymphoma, which is often referred to as waxing and waning, which is a unique feature of indolent lymphomas. Generally speaking, aside from the lymph nodes and the spleen, as well as bone marrow involvement, other sites being involved, so things like the liver, the lungs, the kidneys, etc., is actually quite unusual. Most patients, as we stated earlier, have minimal or no symptoms at diagnosis, and often the blood work is normal. A portion of patients will develop B symptoms, which is sweat and weight loss at some point. So a bit about the biology of follicular lymphoma. So one of the hallmarks that's seen in many or most patients is overexpression of a protein called BCL2. This is a protein that allows cells to evade death. So this is one of the features of follicular lymphomas. The cells don't die when they're supposed to, and so they just slowly accumulate. This overexpression comes from a chromosome abnormality that results in the BCL2 gene being active. And so other mutations are recently identified, including one called EZH2. And it can be a treatment target. Quite a bit is being learned as well about how non-tumor cells, so the environment around the tumor cells, influences follicular lymphoma, and perhaps manipulating that environment can be useful for treatment. Overall, the differences in the mutations in patients' follicular lymphoma, as well as the tumor environment, makes the behavior of follicular lymphoma and response to therapy quite variable. And this is not something that is routinely available to clinicians to help predict how things may go for patients because it's not something that's been fully developed as a useful thing to be done routinely. So we mentioned transformed lymphoma a few times. And so what this is when some of the follicular lymphoma cells turn into a more aggressive non-Hodgkin lymphoma. So usually an additional mutation or mutations has occurred. This is fairly common. So if you follow people long-term, a fair number of them will develop transformation. It's diagnosed with a new biopsy because you need to look and see that diffuse pattern as opposed to the prior follicular pattern in the biopsy. So when do we get a biopsy for suspicion of transformation? Generally, it's when the disease does not appear to be behaving indolently anymore. So there's a sudden change in blood work, very rapid lymph node growth, sudden development of B symptoms, or unusual sites of disease. So patients all of a sudden have, a mass in their liver, for example. So when we stage follicular lymphoma, it's fairly similar to how we stage other lymphomas. The goal of staging really is to determine the extent of disease, and that does help us guide our treatment approach. It serves as a baseline for evaluating response. And so that's another reason that complete staging is very important. Generally, patients are staged with CT scans that include the neck, chest, abdomen, and pelvis. Increasingly, patients are also staged with PET CTs in follicular lymphoma. However, this is not routine in all jurisdictions in Canada due to availability and accessibility of PET scanners. Bone marrow aspiration and biopsy is no longer routine, and so used to be routinely employed for staging. Now it is used if there's unexplained low blood counts, if you need to confirm the patient has limited stage disease, but often it's unnecessary. And so this depicts the staging system. And basically, the staging for lymphomas goes by the number of abnormal lymph node sites. And so stage 1 is just 1 lymph node site. Stage 2 is 2, but fully above the diaphragm, so in the upper half of the body, or fully in the lower half of the body. Both stage 1 and 2 are not very common in follicular lymphoma. Most patients will have stage 3 or stage 4 disease. Stage 4 means that the patient has both lymph node involvement and other structures, so most commonly bone marrow involvement. And so I had mentioned PET scan. And so PET scan for staging and response assessment is recommended by international lymphoma working groups. However, it is not something that I routinely use in follicular lymphoma in Manitoba, and that's because of accessibility. I do use it when it's going to influence my management or when I'm having difficulty interpreting response on CT scan. And so PET scan tracks deposition of radioactive material. It's a radio-labeled glucose. One of the advantages of PET scan over CT is that you can often identify additional sites of disease compared to CT. And so it should be done before, for example, using radiotherapy for limited stage follicular lymphoma to be very sure that you have a limited stage follicular lymphoma. It's also very good at determining if there's any active lymphoma in patients who had a very big mass where it has not fully resolved. And so it can help you determine if that mass is basically just residual scar tissue or if there's active disease within it. And at the end of your initial treatment, clinical trials have shown that the PET results are prognostic, meaning they can predict how long a patient will be in remission, as well as their long-term survival. So prognosis of follicular lymphoma, the prognosis is very good. And so the median survival is over 20 years. and most patients will die from other causes. However, about 20% of patients will have earlier relapses and have a shortened survival because of their follicular lymphoma. And so how do we predict outcomes? So one of the ways is by using a Flippy score at diagnosis, which is clinical features such as stage, age, hemoglobin level. And that is still useful even with our current therapies to help predict how patients might do, but it doesn't really tell us when to treat or how to best treat. The length of first remission is a very good predictor of how patients will do. And often it's not until we see someone relapse very early that we become concerned that their follicular lymphoma is going to be more difficult to manage. As mentioned earlier, the end of initial treatment PET response is a powerful predictor of outcome. However, we don't know if or how we should modify therapy based on that end of treatment response. So treatment of follicular lymphoma, I'm going to kind of go over a number of options and try to put them in the context of the current practices within Canada. So if we look broadly at treatment options for lymphoma, I've listed a number of them here. One is chemotherapy, and so that's a very traditional way to kill cancer cells. Lymphoma cells are very susceptible to chemotherapy. The downside, however, of chemotherapy is it often affects sort of normal cells as well, particularly blood cells, and so people get low blood counts, can get infections, etc. Radiation therapy uses high energy rays to kill lymphoma cells. Lymphoma is especially follicular lymphoma, you can give a very low dose radiation and can be very effective. The problem is that follicular lymphoma is usually widespread, so it's usually stage 3 or 4, and so it has limited use because we can't radiate the whole body. But for patients who have disease that's just in one spot, or if we're looking to just control symptoms from a single spot, it can be very useful. Monoclonal antibodies, as well as targeted novel agents, are designed to target a specific protein on a cell, or sometimes interrupt talking between cells and result in cell death by one of those two mechanisms. Immunotherapies are one of the new advances in follicular lymphoma and really lymphoma and oncology overall. These are different ways to use our own immune system to attack cancer. They come with different side effects than chemotherapy. Because they work so differently, patients who have not responded well to chemotherapy can often still get a good response. Transplantation in follicular lymphoma is where we infuse healthy stem cells or bone marrow, and it's something that is used sparingly in follicular lymphoma, generally considered for patients that are young and have an early relapse. For all of these treatments, we really are always needing to balance the toxicity and the effectiveness, especially considering that our goal of treatment is to alleviate symptoms, and we want people to be able to go back to work, maintain a good quality of life in between therapies. And so I want the therapy to work for a long time, but without people being really sick for a long time. So I'm going to talk about our initial treatment approach. And so many patients have no symptoms and have a small disease burden. And these are the patients where we generally consider observation. The reason that we consider observation is there's no benefit of early treatment ever demonstrated. And what observation usually means is clinical assessments at different intervals. Imaging is not necessarily part of that routine clinical assessment. And so observation is often referred to as watch and wait. And so again, just highlighting, multiple trials have looked at this, giving early chemotherapy versus waiting until a certain set criteria develops. And those have not found any benefit related to survival in patients. And thus, there's no benefit to intervening earlier. And there can be downsides. So we can introduce complications and side effects sooner than we need to. On average, patients do need treatment within about 2.5 years from diagnosis, but there's a portion of patients, 1 in 5, have not required treatment by 10 years of follow-up, and some that never require therapy. And so by treating earlier, we're over-treating those patients that are ultimately never going to need it. There are some advantages to waiting, so you don't introduce complications, but also you don't introduce potential drug resistance until you need to, basically. So during watch and wait, what should a patient do? Well, I think that the most important thing is for the person to feel comfortable with the treatment plan, and that's often the focus of the initial consultation, as well as several of the first follow-up visits. And so I want people to feel comfortable that this is the best approach for them. And that, we know this based on many studies. And so ask questions about, what would need to change? What should I be looking for? Importantly, just report any change in your health, because lymphoma doesn't have just one specific symptom. And so sometimes, things that you don't think are related, like, oh, I have this new shortness of breath and I just can't catch my breath. Like sometimes that could be a manifestation of your lymphoma. And so report new symptoms so they can be investigated. While you're being observed, try to take care of yourself, because people who are healthy and active tend to tolerate chemotherapy much better. It's also a good idea to learn about your lymphoma. And that way, when you are needing treatment, you're going to feel more prepared for it. Get whatever support you need, during this time period. Because it can be difficult for some patients because they feel like they're just kind of waiting to do something about their cancer. And so often people will find that they need support from psychosocial oncology, as well as peer groups, etc. During the watch and wait period, it's also a good time to get immunizations because you haven't been treated yet. And so your body will develop a better immune response to them. So things like considering the shingles vaccine, pneumonia vaccines, etc. during this time period. So when we look at a typical course of follicular lymphoma, you can see from this graph, that many patients are observed initially. They're observed until their tumor load increases to a certain point, such that treatment needs to be initiated. Usually that treatment is time limited. Most commonly in Canada, it's with a combination called bendamustine rituximab that's given over 6 months. I'll talk more about that later. Often patients have a period of maintenance rituximab thereafter, and then they remain in a remission. Durations of remission are long. So in the clinical trials that looked at giving bendamustine rituximab to patients as their first treatment, not even half of patients needed retreatment after 10 years of follow-up. Eventually, though, we do expect most patients to need treatment again, and the intervals between treatment tend to shorten as people get further along, because the lymphoma cells that remain are ones that are generally more challenging to kill, particularly with repeated use of chemotherapies. Okay, all right. So indications for treatment. So one of the indications for treatment is symptoms that are attributable to lymphoma. And sometimes it is hard to be certain if the symptoms that you're having are from your lymphoma or ones that we anticipate to get better with treatment. And so that's something that everyone needs to discuss with their physician, and usually based on combination of listening to the symptoms and the looking at the images and experience, we can sort of what's likely attributable to the lymphoma or what could be from something else, in which case it's not going to get better with treatment. Low blood counts because of bone marrow involvement would be another cause to treat. Any threat to organ function, so say the lymph nodes are getting so big, they're causing your kidney to swell, or they're causing fluid to accumulate around the lungs, those would be indications to treat. Bulky disease, so what does that mean? So a normal lymph node is about 1 centimeter. And one of the more common criteria to consider treatment is any lymph node diameter greater than 6.5 centimeters or 3 that are greater than 3 centimeters. And so that is kind of one general guide that many people will follow. Really big spleen that's causing symptoms like bloating or weight loss. Or if the disease changes into a more aggressive lymphoma, then that would be an indication for treatment right away because it's no longer follicular lymphoma alone. And so what is our initial therapy? So I have put in here rituximab alone, although I will state that this is not routinely done throughout Canada. So I think that only British Columbia has rituximab alone for low burden asymptomatic follicular lymphoma on its funding formulary. And that is because of what we discussed earlier, that there's no benefit in long-term survival when you treat earlier. With that said, there is some data that show us that patients that are asymptomatic with low disease burden may have less anxiety if we give them rituximab alone. And further, it'll be much longer until they require treatment again compared to if we observe alone. And so this is something that may be discussed with your hematologist or oncologist. I also consider rituximab alone for a very frail patient with many comorbidities. In this patient, I really want to minimize toxicity. And so if they are having symptoms from lymphoma that has a significant burden of disease, but I don't think they can tolerate chemotherapy with rituximab, that might be my choice. In a younger patient without comorbidities, usually it is not my choice because the response is not going to last as long as when I combine it with chemotherapy. And so for people that can tolerate it, I would prefer to get a longer duration of response. And so I usually would combine with chemotherapy. So radiation therapy is used as the sole treatment in a small number of patients. Generally, that's patients with stage 1 disease, or sometimes a stage 2 that is encompassable by a single radiation field. The main initial therapy for most people when they are at a point that they require therapy is a monoclonal antibody against CD20, usually rituximab, because studies haven't shown a benefit of giving a different monoclonal antibody upfront, combined with chemotherapy, most commonly bendamustine. And so what is a monoclonal antibody? So a monoclonal antibody is basically an antibody that targets a protein on a cell. So on B cells, we have CD20 protein. And so the monoclonal antibodies most commonly target that, although some newer ones are being developed against CD19, which is also a protein on B cells. And so the two main monoclonal antibodies against CD20 that are approved for follicular lymphoma are rituximab and obinutuzumab. Obinutuzumab is a bit more potent and is useful in specific situations, particularly if patients have developed resistance to rituximab. So what is chemotherapy? So this is the backbone of most cancer treatments. I think chemotherapy, can get a bit of a bad rap, but is very effective in follicular lymphoma. We just have to be aware of the risks and benefits for individual patients. Just want to talk a little bit more about radiation for follicular lymphoma. So radiation uses X-ray beams to create DNA damage, which results in cell death. This is very effective in lymphoma because lymphoma cells are very, very susceptible to radiation. It's mostly used, as I've already mentioned, to treat localized disease, but it can also be used for symptom control. The side effects usually depend on the area being radiated. So I'm going to talk a little bit about the most common combination for initial treatment, and that is bendamustine and rituximab. And so when I speak with colleagues, whether it be across the province or from other provinces, this is by far the most common initial therapy. And the reason for that is it's very effective and it's also very tolerable. And so that combination is what leads us to use this. It is given intravenously, the bendamustine, 2 days in a row every 4 weeks, combined with rituximab on day 1. This treatment is, generally speaking, one that most patients can handle. It can, however, cause some problems, with the most common side effects being tiredness, nausea, constipation, and low blood counts. Sometimes it has to be dose reduced, particularly in patients that are over age 70. And thankfully, this does not seem to influence how long the remissions last for. The nice thing about bendamustine is that patients generally do not require a special IV line, so no PICC line, no central line needed, and they do not lose their hair. So occasionally we'll use an alternative regimen, and I would say the next most commonly used regimens are R-CHOP or RCVP. Basically, these are very similar regimens. RCVP is simply the same, but without the doxorubicin. And so times when we may use these is if there is evidence of diffuse large B-cell lymphoma or transformation with the follicular lymphoma, then a patient would require R-CHOP to target the more aggressive lymphoma. We may also consider this treatment in a patient that is a young female wanting to have future pregnancies, because there's not a lot of data on fertility post bendamustine and rituximab. RCVP is definitely gentler and very tolerable, but tends to have a shorter duration of remission than BR, and that's why it is not our preference. So common side effects of these chemotherapies. So you do get hair loss if you get CHOP. You also might get muscle sores related to CHOP, less common with bendamustine. Nausea and vomiting are very common chemotherapy side effects. A little bit more common with CHOP than bendamustine. Most patients can, in both instances, it can be controlled well with medications. Fatigue is by far one of the most common side effects of any of these treatments. I try not to initiate therapy for lymphoma based on fatigue alone, because I find I usually make it worse. And so that is something that you should keep in mind if your main symptom of your lymphoma is fatigue. The one exception to that would be as if you are very anemic and have very low hemoglobin from your lymphoma, then we actually may improve that with our chemotherapy. Fever and infection is a common side effect of chemotherapies. The risk of fever and infection varies depending on the regimen that you're getting, slightly higher with CHOP compared to bendamustine. Low blood count, similarly, are a common side effect. There's some longer term issues with chemotherapy. Heart function may be a longer term issue related to CHOP, so that needs to be monitored. Both CHOP and CVP can come with peripheral neuropathy, and so numbness in the hands and feet as side effects. Thankfully, bendamustine does not cause or worsen peripheral neuropathy. Common to all chemotherapies can be variable degrees of troubles with memory or concentration, so-called brain fog. Patients may develop fertility issues. The risks of that vary depending on the treatment and how old you are when you receive treatment, as well as gender. Post-treatment fatigue is by far one of the most common long-term issues in clinic, as well as emotional distress. And so those are things that people frequently struggle with and need to seek help regarding. There's also the long-term issue of infection risk, which kind of has been more prominently on people's minds over the last couple of years during the pandemic. So response evaluation. So after you do have treatment in follicular lymphoma, most patients should have repeated imaging, usually with CT and or PET scan to assess response. Not everyone will have a complete remission, although many patients will. Even partial remissions can be stable for many years, although patient may need more imaging if they do have partial remission to ensure stability. Patients who have a partial remission may convert to a complete remission during the maintenance rituximab phase of therapy. So just a word about maintenance rituximab. So what this is receiving rituximab on an ongoing basis after your initial treatment. Usually it's given every 3 months for a total of 8 doses for a total duration of 2 years. Studies have looked at longer durations of maintenance, for example, 4 years, and found no benefit of going longer with more side effects or toxicity like immune system issues. Overall, there is a need to balance the risks and benefits when you consider if you should take maintenance rituximab. So it's something that, is not necessarily prescribed to all patients. And the reason for that is it's going to prolong and potentially deepen immune system suppression. So for some people that are, for example, already prone to recurrent bronchitis or pneumonias, that's a really big deal, and they may not benefit from maintenance rituximab. And it does prolong remission, but it doesn't change how long you live. And so that's why it should be weighed carefully in considering a person's goals. And so many people will want to prolong remission, but not all. Some patients value being off therapy and not having that ongoing immunosuppression, particularly given that it doesn't change their long-term outcome. So what about relapse of follicular lymphoma? So one thing I do want to highlight is that repeat biopsy is important. This is important to ensure that it's still just follicular lymphoma and that it hasn't transformed. And so if possible, everyone should have a repeat biopsy at time of relapse. Again, generally speaking, at relapse, if the disease burden is low and a person feels well with no potential organ compromise, we can wait till one of the indications to treat develops to initiate the next therapy. There are many treatments available, and really the challenge in relapsed follicular lymphoma is knowing what the best next treatment is, because there's no consistency in this, and it really is variable depending on different goals. So is your goal to minimize toxicity? Is your goal to have a really long remission again, et cetera, et cetera. So talking with your treating physician about your goals is very important. I would encourage consideration of clinical trials for new agents in relapsed follicular lymphoma, because that's how we determine where those new therapies might fall in terms of new treatment priorities. So at relapse, I'm just going to run through some of the more common treatments. Rituximab alone is sometimes considered, and often it's one of the comparisons or controls on clinical trials. I don't tend to use rituximab alone very often. If someone has a very, very long remission to their initial treatment and they're frail or have other medical problems where we just really want to minimize toxicity, I might give rituximab alone. Generally speaking, we're treating with a monoclonal antibody against CD20 again, and chemotherapy. Sometimes we're switching to obinutuzumab for patients that are rituximab refractory. And so we'd be giving either rituximab or obinutuzumab with CHOP if the patient had bendamustine first, if we think they can tolerate CHOP, or giving usually giving obinutuzumab or rituximab with bendamustine if they've never had bendamustine. Generally speaking, we're not repeating the same treatments again. We're using something different than the first time. Another treatment that is increasingly used in relapse is a drug called lenalidomide with rituximab. We'll talk about that more on the next slide. So sometimes transplantation, either an autologous transplant or an allogeneic transplant, is considered. This is considered particularly in people that relapse very early and are less than age 65. And so the risks and benefits of these procedures that have significant risk of even death from the procedure need to be considered carefully. But for some patients, it can help them achieve a very long, durable remission. An allogeneic transplant is a potential cure for follicular lymphoma, but one which comes with a lot of risk and even long-term issues. Immunotherapy really is the biggest advance in follicular lymphoma, as well as, like I said, in all lymphomas. It's kind of the big news. And so I'm going to talk specifically about two immunotherapies. One is specific antibodies, and the second is CAR T cell therapy. And so this slide summarizes some of the novel therapies. Lenalidomide and rituximab perhaps isn't that novel anymore. It's been funded in most provinces within the last couple of years, I think. Lenalidomide is a drug that's considered an immune modulator. Sometimes it's referred to as being chemo-free. I don't necessarily consider it to be that much different from chemotherapy, to be honest. I find that there is still significant issues with blood counts and tolerability, although it may be more tolerable than alternatives such as CHOP. It'd be easier to administer. It is 12 months of treatment. The lenalidomide is oral, though, and the last 6 months of treatment are lenalidomide alone. Common side effects are rash and diarrhea, and patients often have to take a baby aspirin to decrease risk of blood clot that is associated with the treatment. Other treatments that are not yet available, but are probably coming sooner, ones that you guys would like to know about. So there is an oral treatment called tazemetostat. And this is an EZH2 inhibitor. So if you remember earlier, I talked about patients having this mutation. So not everyone has this mutation. Only about 20% of patients with follicular lymphoma have it. It's actually a good prognosis mutation. But this is an option for people, and it can be a tolerable option compared to intensive chemotherapy for someone to take at relapse if they have an EZH2 mutation. It does take a while to see a response, so it's probably not for someone who has a very high number of symptoms. Presently, it's not readily available in Canada. However, I think that'll likely change within the next couple of years. In terms of immunotherapies, the two that are applicable to follicular lymphoma are mosunetuzumab, and this is an immunotherapy, and it's an immunotherapy that it's called a bispecific antibody. And so it's bringing together immune system cells with tumor cells. This drug is FDA approved for follicular lymphoma. It is not yet funded or easily accessible in Canada, but I do expect it to be reviewed by our Canadian Oncology drug review process and potentially available within the next couple of years, hopefully. The other new immunotherapy is CAR T immunotherapy. And so the two main products for CAR T that are FDA approved for follicular lymphoma are axicabtagene siloleucel and tisagenlecleucel. These are CAR T products that have been used in more aggressive lymphomas in Canada for some time. And they will be becoming available for follicular lymphoma in the next few years. So what is a CAR T cell? There's a specific CAR T session at the conference. And so I encourage you, if you want to learn more, to attend that, because I'm just going to give you a very basic overview. So basically, a CAR T cell is when you take a normal T cell from a patient. So from you, we take your normal T cell, and then we genetically engineer it to attack your tumor cells. And so in lymphomas, generally CAR T cell has been directed against CD19, which is a common B cell marker. So basically, we're just harnessing your own immune system to attack your lymphoma. So this is a very neat concept. It is very complicated though, and that makes it costly. And as well, there's a lot of logistical issues with administering this. And so in Manitoba, we've been able to send patients for CAR T cell therapy for aggressive lymphomas for several years, but we do not actually give CAR T cell therapy ourselves yet in Manitoba because of the logistical issues that are present. So which CAR T products are coming in follicular lymphoma? So the tis-cel or the axi-cel. So tis-cel was just reviewed nationally and received a positive recommendation for funding with some caveats. One of those caveats being that the company need to make it a bit more accessible price-wise. And so usually there is a significant lag between that national approval and the provinces each agreeing to fund, as well as getting, because there's contracts that have to be negotiated with the company. But if we have this national positive recommendation, it generally means that at some point, not too long down the road, this will be accessible to some patients. The other CAR T cell product that is undergoing review is axi-cel. Both of these products have been studied in follicular lymphoma that's relapsed after at least 2 prior treatments. They do have high response rates, even in patients that are very refractory to other chemotherapies in particular. And so that's what makes everybody very excited. I think there is some uncertainty though, so it's really unclear if this is a potential cure or not, because we don't have long-term data. And in addition to cost, there are significant toxicity concerns. So in the short term, patients can develop something called cytokine release syndrome. And you can, even if you have a high-grade cytokine release syndrome, be very, very sick, like, really low blood pressure and needing to be in ICU, confusion. And so, that can be very serious. It also comes with long-term depletion of the immune system. And so higher risk of infections. And so this is something that is very exciting for patients that have run out of treatment options or have early relapsed follicular lymphoma. But it's something that is not for everybody necessarily, because I don't think we need to introduce this kind of toxicity for the average follicular lymphoma that can sometimes stay in remission for well over a decade with chemotherapy. So the other immunotherapy are bispecific antibodies, and there's a lot of these antibodies being developed. Basically, the idea is you take T cells and you direct their immune system kind of killing functions towards your tumor cells. And so unlike CAR T cells, these are a product that is kind of just like ready and waiting. One of the disadvantages of CAR T cells, and one of the reasons it's so costly, is that we have to manufacture your own personal T cells to attack your, tumor. Whereas this antibody basically just links them up. And so everyone gets the same antibody. It's not, and so there's, you cut out that manufacturing kind of process, but have a similar kind of, mechanism of action. And so mosunetuzumab is the bispecific that is kind of furthest along in development for follicular lymphoma. This is a T cell engager, sometimes referred to as a BiTE antibody that unites CD20, which is on lymphoma cells, and CD3. This bispecific has been studied as a third-line treatment, or even patients who've had even more treatments than that. The studies included a lot of high-risk patients. So there's been a high portion of patients that relapse early, so within the first 2 years post-treatment, or patients who have relapsed after a transplant. And despite being very high-risk patients, there's a very high portion of complete remission from bispecific antibodies. So that has led to a lot of excitement about this treatment. There still is the risk of cytokine release syndrome, usually when we initiate the treatment. And so there's sort of like a step up process where you give like more and more and more. 7% of the patients will require hospitalization. And so, it still comes with some risk, but a bit more logistically feasible for larger number of patients than CAR T cell therapy is probably. There hasn't been studies comparing these two approaches, which is really one thing that I think is needed so that we can understand, how they compare to each other. So to summarize, so I kind of went over some of the basics of follicular lymphoma, and many patients will be asymptomatic at diagnosis. You can go a long time without needing treatment. There's no benefit of treatment with low burden disease. And generally, this is associated with a very long-term survival. We have a lot of good treatment options, and those include chemotherapy, as well as increasing numbers of newer treatments such as immunotherapy are coming. The best sequence of treatment, especially at relapse, is very unclear and really needs to take into account how long the initial relapse, or how long the initial remission was, and patient goals, other characteristics such as other medical issues. One unmet need is how can we predict people's course? And so are there people that I can give less treatment to? So how do I know if you really need maintenance, for example? There's been one study done that tries to address this, looking at people who have a complete remission on PET scan. And unfortunately, they found that maintenance was still of benefit, meaning people still had longer remissions if they got maintenance. And so that wasn't the best way to decide. And so ultimately, for something like maintenance, it just comes down to preference. To prefer to put off chemotherapy longer, even knowing the duration that's predicted with the treatment you had, or do you prefer not to be on treatment and potentially have your immune system recover a bit sooner? And so it's really just patient preference, honestly. Who is going to relapse early? So patients with follicular lymphoma that progress within 24 months of treatment, these are people that really need more options, better treatments. They are people who tend to have poor outcomes, and we have to treat very aggressively. And that is really, I think, the focus of new treatments and trials. And so that concludes my presentation. And I am happy to take any of your questions at the indolent lymphoma session. And I thank you very much for your time.
Thank you, Dr. Skribeck, for that wonderful presentation. We appreciate your thorough review of this lymphoma subtype in terms of diagnosis, prognosis, and treatment options for Canadians. Now I'd like to direct the audience to attend the breakout session after this presentation to have your questions answered live. Thank you.